Evening. My name is Alana Silber, and I am the CEO here at Sharsheret, the National Jewish Breast and Ovarian Cancer Organization. And we're really glad to see all of you here tonight. We know these are very challenging and uncertain times for many of you, and even the timing of this call could be difficult. So we will be recording this call for people to access it on Sharsheret's website, sharsheret.org. After the webinar is finished, and will be saved there. We are mindful of your privacy, so if you would like to participate anonymously, feel free to turn off your video and to change the name on your screen. The only faces that will appear on our website will be those of the speakers. And just making sure, there's a lot of Zoom conferences out there, just making sure you're in the right place. Tonight's webinar is focusing on living with ovarian cancer and COVID-19, presented to you by Sharsheret. Sharsheret has actually been an organization that's been providing virtual support since our inception back in 2001, providing emotional support, mental health counseling, financial subsidies, and up-to-date health information for the last 19 years. And so when this pandemic started to hit, Sharsheret's team of mental health professionals were quick to respond to the urgent concerns of women like you, women who are living with ovarian cancer, and women who are living and facing breast cancer. So tonight is a part of a series of webinars that we've been presenting with up-to-date information from experts in the field. So I really thank you all for being with us today. Today's webinar was made possible with support from some of our sponsors that I'd like to share their names: the Sigmund and Edith Blumenthal Memorial Fund, Daiichi Sankyo, Eisai, GSK, and Seattle Genetics. We're very privileged to have two incredible speakers with us tonight. Our first speaker will be Kimberly Tronick, who is a Sharsheret peer supporter in our ovarian cancer program, and will share her story with us today. And we have Dr. Brian Slomovitz, who is a gynecologic oncologist at Broward Health Medical Center in Fort Lauderdale. In addition, he is a professor of obstetrics and gynecology at the Wertheim College of Medicine, which is part of Florida International University. Dr. Slomovitz has published hundreds of papers and abstracts in the field of gynecologic oncology. Currently, his particular interests are in early detection of ovarian cancer, PARP inhibition for ovarian cancer, robotic surgery, and immunotherapy for endometrial and cervical cancers. So I think that we have our experts on the call tonight. This is meant to be interactive in the way that you can share your questions and comments in the chat on the side, and I will be facilitating a Q&A at the end. Some of you have sent questions in advance, but if questions come up along the way, feel free to put them in the chat and we will address them on the call. So now it is my pleasure to introduce you to Kimberly, and we'd love to hear your story.
Thank you so much, and thank you for having me. I'm so grateful to be able to share this experience. As advertised, my name is Kimberly Tronick. I'm a freelance writer in Los Angeles, and I'm also a two-time stage 3 ovarian cancer survivor. And I think one key point to my journey that I really am passionate about sharing is the reason my diagnosis was such a shock. And the reason for that is I had no known family history of cancer, and I also had no known family history of the BRCA gene mutation. So my father is of Ashkenazi Jewish descent. My mother is Swedish. And back in the early 2000s, when my mom first heard of BRCA, she actually approached a geneticist in Boston and said, should we get testing for my daughter? So again, this is about 20 years ago. And the geneticist told my mom, since we had no family history of cancer or of the BRCA gene mutation, that I wasn't considered high risk and that we didn't need to get me tested, which we now know. Big mistake. We should have insisted on getting tested, but we didn't. We took the geneticist's word for it. So in 2017, I started getting some off and on pains in my upper right abdomen, and I went to urgent care. I got checked out. They said nothing was wrong. So a couple of months go by and I'm still getting that pain, but all of a sudden I noticed I had a very swollen abdomen. I started feeling queasy. I couldn't keep food down. I had difficulty eating. So My father, bless his heart, he's a pathologist. He immediately knew that I had ovarian cancer, but he didn't want to scare me. And obviously we couldn't know for sure without a biopsy, but he said, go to the ER, get checked out. So I did. I went to the emergency room. They kept me overnight. And excuse me, after several tests, they woke me up the next morning and gave me the news. And they said, you know, we're going to do a biopsy, but it's, you know, it looks like it could be stage 3 cancer. There was tumors on my ovaries, my uterus, my spleen, my liver, and all around my stomach. But the doctor said, you don't make sense to me. You're young, you're healthy, you're 36, you have no other issues, you have no family history of cancer, you have no family history of BRCA, you just don't make sense to me. So he said, we're going to do some genetic testing on the first day of chemo, which we did, and surprise, it came back positive for the BRCA1 mutation. So then my whole family went and got tested as well, and lo and behold, all of the men on my father's side of our lineage tested positive for BRCA1 as well. So since that genetic mutation causes breast and ovarian cancer primarily, all of those men were just kind of silent carriers, and I'm the first woman that cancer actually manifested in. So that's why it was very frustrating to know that I should have been tested all those years ago when my mom asked the question, but we didn't. So we quickly jumped into treatment, which was chemotherapy and then a hysterectomy where they also removed my spleen. We finished off with more chemo. And then the following year, I actually got like a small recurrence where we found a liver tumor. So I jumped back into chemo, got liver surgery, and then I got a preventative double mastectomy just to be on the safe side because of the BRCA gene mutation. And now I'm happy to report I'm finally healthy, thank you. And I really just want to use my story to help inspire or just help anyone that either is facing it or will have to face it or is a caretaker. I just want to use my story to help people. That's why I'm very honored and happy to be able to blog with Sharsheret, to be a peer supporter with Sharsheret, to share my story with Sharsheret, because I really think that community and support are everything when you're going through this kind of journey. So I will always be grateful to Sharsheret for that reason. And I'm just happy to share this information with anybody that could find use of it. So that's the story.
Thank you, Kimberly. I mean, it's good to hear good news at this time, and you know, all of us are here for you and so appreciate you giving back. And we know that we learned so much from the women who share their experiences. So thank you for sharing so openly and so warmly, and really continued good health. As we turn from the personal to the professional, I'm glad to turn the floor over to the doctor. So here we go.
Great. Thank you very much. And thank you for allowing me. I hope everyone could hear me okay. Thank you for allowing me to present to your group. I guess as we're waiting for the professional, I guess I'll speak for a couple of words. That was a joke. First of all, I'm a gynecologic oncologist. I'm a researcher. I'm a clinical trialist. Right now, I have my academic appointment at FIU. For full disclosure, I'm going to talk about different things that go on in ovarian cancer. Nice things like drug approvals and things that are better for patients. For full disclosure, you know, part of my work is to work with these drug companies. So, you know, it's important that we say that whenever we're speaking to a group, but all the opinions are my own. And you know, my goal is really, and my goals for being here is to work with groups like yours and Sharsheret and other patient advocacy groups to better relay information, to really offer support, to let people who are out there who are scratching their heads, help them get some of the answers they're looking for. And, you know, I like this call because I'm only going to speak for about 10 minutes now, and then we'll have a lot of time for question and answering and things like that. If you put your pointer over my name, my email address is there, so I'm happy to answer any emails. I have no problem with that at all. So what I figured, you know, we're talking about ovarian cancer and COVID, and COVID's really taken over our lives. I figured the way I'd go through this is really run through ovarian cancer. And Kim, thank you very much for your story. I think whenever we hear stories like that and have a smiling face on the other side of the room, or I guess now the other side of the webinar, it's always nice to hear. So thank you for sharing. And I know it takes a lot of energy to do that. So thank you for that. But so I sort of want to give you from our perspective what goes on medically with ovarian cancer. And then along this journey that we're going to go on, I'll talk about how COVID has changed that a little bit for us. So first of all, similar to Kim's symptoms. Ovarian cancer does present oftentimes with abdominal symptoms, abdominal swelling, abdominal pain, bloating. Sometimes it could be a cough, sometimes pelvic pain, sometimes vaginal bleeding. It's still the most lethal of all gynecologic or women's cancers. And the reason for that really is because we don't have an early detection tool for it. Most women are diagnosed with stage 3 or 4 disease. So that we need to do better at that. So for the typical patient, some of the risk factors, Kim mentioned a big one: hereditary, BRCA mutations. The 10 minutes I have can't even touch the surface of talc. So I'm not going to go there. But as you all know, there's a lot of talk about baby powder and ovarian cancer in the news. We need to do better identifying symptoms, and then patients, ultimately, they get to see a gynecologist or gynecologic oncologist. Typically, they have as I mentioned, stage 3 or 4 disease. That means there's spread of disease in the upper abdomen. How does ovarian cancer spread? Imagine taking a fistful of sand and throwing it on the inside of a wet balloon or the inner abdominal cavity, and it spreads like seeding. And then that's exactly what we call it medically, seeding. So it goes into different areas. Now here's the first line of treatment is chemotherapy with surgery. In Kim's case, she got chemotherapy first. Here's the first point about COVID. With COVID and with keeping patients out of the hospital, usually in the past we did have to choose between doing surgery first or chemotherapy. With COVID, we've really been giving more of chemotherapy first, in the hopes of ending this pandemic. And I think it worked. As we saw the curve flatten, we kept the quote unquote healthy patients who have ovarian cancer out of the hospitals where we're loaded with patients who are intubated and unfortunately suffering from that disease. So while the first line is usually a combination of chemotherapy and surgery, it still is, but instead of having the doctor choose, we'd go for chemo first to keep patients out of the hospital. Now, the good news with ovarian cancer, the drugs we give are something called Carboplatin, and I know a lot of people here know about these, some of you may not. Carboplatin and paclitaxel. It's the paclitaxel that causes the hair loss. Unlike me, your hair will grow back, mine won't. So, and patients do pretty well with it. Patients go through 6 cycles of therapy, and about 90% of the time, the chemo goes, the cancer goes away. So it's usually 3 cycles of chemo, surgery. With COVID, surgery could have been pushed out a little bit later, but then they'll finish surgery in 6 cycles, and for about 90% of the people, the cancer's gone. In the past, we'd say, go live your life, enjoy, do the best you can. We've really changed that recently, and even with COVID, the FDA has really pushed some major drug approvals, which I want to talk to you about. And those drugs, one of the drugs we've had is an IV drug called Bevacizumab. It's an anti-vascular drug. Imagine if a tree grows, it needs roots. If a tumor grows, it needs blood vessels. Avastin would prevent that blood vessel formation. Some of the approvals, though, that we've seen are something called PARP inhibitors. And PARP inhibitors used to be a class of drugs that in 2018, that really only, if you had a BRCA mutation, you would know about in the first line setting. But in the European meeting that happened last October, before all of this went on, there were some major presentations showing that PARP inhibitors actually work for all women, not only those with a BRCA mutation. And here comes to the second sort of caveat about COVID. So up until this pandemic, we had a choice. Should we give maintenance therapy, Avastin or PARP inhibitors? Which one should we give to patients, or nothing? I'm a big believer that maintenance therapy works. Giving patients a drug to suppress the disease helps keep it away. We've been doing more and more of PARP inhibitors. The key reason why, it's an oral drug. You don't need to come in to get the infusion. So because of COVID, because of the pandemic, and keeping patients out of the hospital so they don't get infected, we've been using more oral drugs. The key 2 points for patients: 1, they're still effective. So don't think that just because you're taking a pill, it doesn't work. It actually does work pretty well. The other point, and sort of the negative point, they still have side effects. So even though it's an oral pill and it's not something that's going in your arm, there's still side effects associated with the PARP inhibitors that we need to monitor. And with COVID, sometimes patients will get blood drawn at home or or go to a doctor's office instead of the hospital to get tested. Now, again, I promise I'm going to stay on time. So that's the good news of ovarian cancer in the first line. 90% go away. We put patients on a maintenance therapy. Unfortunately, about 60 to 75% of the time, it comes back. We have better drugs now and better combinations of drugs to get rid of it again. And in particular, same as in the first line, PARP inhibitors work in the second line for a maintenance therapy. So we give chemotherapy again when, God forbid, it comes back. But then we have these PARP inhibitors, oral therapies, that we're choosing to keep patients out of the hospital to keep the disease away longer. There again, it's important to monitor symptoms and to make sure that the blood counts are okay and things like that, but it's giving us an option. Now, unfortunately, in some patients, the cancer is going to keep coming back. What I like to say, ovarian cancer is becoming more and more of a chronic disease, not like diabetes or hypertension, but like breast cancer. It goes, it comes, it goes, it comes. When we move later in the lines of therapy, not only are we looking for drugs that have efficacy and are effective, but we're also focusing on quality of life. Now, one of the big factors of quality of life, and one of the things that we're really losing out with in this pandemic, are the supportive services that many cancer centers, whether they be academic or community centers, have for our patients. By locking the doors and only letting the sickest patients in, we're losing out on some of the support groups that are hospital-based, some of the massage therapy, the pet therapy, all the different things that we did for our patients. That's why events like this are so important. It's a new norm. We're communicating, and we're, a year ago, we would be doing this in the waiting room of our office, talking to 10 or 15 patients, or at a hotel in a ballroom, talking about this in a nice setting. It's important that we do these support type of groups because this is part of our therapy. It's not only the treatment for recurrent disease, but it's also maintaining our quality of life, knowing that you're not alone, knowing that there's other people in this, and that it's a good support for not only patients, but their families and loved ones as well. So in the second line setting, we want to work on support groups, obviously, and actually using different drugs. And that's where, again, the PARP inhibitors, and there's some other oral therapies. We're using oral biologic therapies, hormonal therapies that could help keep the disease away longer, but also keep patients out of the hospital. So, the good news is, and to summarize, the immediate ramifications of the pandemic in relation to COVID is that we're not seeing higher rates of recurrence. We're not seeing higher rates of death due to the disease. We're seeing numbers that are staying the course, but we're actually need to work on patient support things, support groups. We need to work on maximizing our use of the oral therapies. And as we reopen, I'm in Florida, and I think we're going to have a disaster in this state. But as we reopen, we really have to be careful to do it slowly and carefully. Not to show up in your doctor's office without a mask and to sit in a crowded waiting room, but to make sure that we're maintaining our social distancing, we're doing our face masks and things like that. I know I sort of covered a lot in a short period of time, but I know I also want to make sure that we have a lot of time for questions and things like that. So I'll leave it at that, and I'll open up the floor for questions.
Okay, so thank you so much, and I'm happy that you touched on a lot of things which will trigger questions for people as we go forward. And thank you for your focus on support. Shared is all about quality of life, and we love to partner with the medical community to complement the incredible work that you're doing. So thank you for that. We had some questions that came in online. There's a question in the chat, and I have some in my email. So we're just going to run through them, and we'll start with the first one that came in on the chat and asked if you have any statistics regarding immunotherapy drug trials such as Tecentriq. Have you seen any improvement in recurrences with immunotherapy drugs?
Yeah, that's a great question. So immunotherapy is one of the key therapies now we're using for all of cancer. In gynecologic cancers, we're seeing that diseases like cervical cancer and endometrial cancer actually have pretty high response rates to immunotherapy. Unfortunately, the data to date, there's not a lot of high responses to immunotherapy in ovarian cancer. It doesn't mean it's not going to work. It means we haven't figured out the right combination yet that'll work, that will work. It's important to study. If you're on a clinical trial right now, I don't want you to get upset, thinking I'm telling you bad news. You know, it's important to these trials. And, you know, I have about 3 or 4 different trials now looking at immunotherapy and ovarian cancer that we're investigating this. Real quick on immunotherapy, if you can imagine, the immunotherapy, the whole purpose is for your body to identify something that shouldn't be there. Unfortunately, ovarian cancer is a little bit sneaky, and the body does not recognize it as something that shouldn't be there. So we're working on ways, we're injecting patients with viruses that stick to the cancer to hopefully stimulate the immune system to work. But we're not there yet. But I would encourage you to think about those clinical trials.
Okay, thank you. We talked a little bit about BRCA positive, and so the questions come in: is PARP therapy effective if you are BRCA negative and the carboplatin wasn't that effective?
Yeah, that's a great question. And you know so it's important. So for PARP therapy, the best predictor of response to PARP therapy is not BRCA status. BRCA status is important, but the best predictor to response to PARP therapy is platinum sensitivity. So in this example of where someone is BRCA negative and was platinum resistant, personally, I'm not overly excited about PARPs. I will use it at some point. Hopefully we get a response to some other agents, but it won't be my first choice. In those situations, I would look for other markers. I would do next generation sequencing, sequence the whole tumor to see if there's other targetable mutations that may be there. And there's also other chemotherapeutic agents like Doxil, gemcitabine, topotecan, which may have an effect. But for a patient, for if they're BRCA negative, I'd like them to be something called HRD, or homologous repair deficient, and that's sort of a scientific term, but it's also just another way of saying I'd like the tumor to show signs of PARP sensitivity.
So while we're talking about genetics, first of all, I want to just put it out there, little self-promotion, but also to be helpful, that we have a genetic counselor on staff. So a lot of the language that may seem foreign to you, Peggy is amazing, and you can call her and speak directly, and she can, you know, help explain a lot of what your doctors are sharing with you, and talk to you a lot about the genetics aspect, so you are prepared for your appointments with the doctors. Also on the subject of genetics, I know that Kim talked a little bit about her genetic mutation. Is there a difference for the risk for ovarian cancer if you have a BRCA1 or a BRCA2 mutation? And for men who have a mutation, do they have to worry about, what cancers do they have to be worried about? So it's a super question. Yeah,
no, that's a great question. So number one, with a BRCA1 mutation, yes, there's a higher risk. It's about 40% chance of ovarian cancer, 20 to 30% chance of ovarian cancer with BRCA1, and it's about half of that with BRCA2. So it's more common with BRCA1. There's other, obviously breast cancer, 80% of the time. You can get a breast cancer with a BRCA mutation, either one. For BRCA1 mutations, there's also a risk for uterine cancers as well. In men, we're worried now with BRCA mutations, we're worried about some prostate cancers, some pancreatic cancers. So we're learning more and more, and it's great that you guys have a genetic counselor. They're working with you. I do think it's important, you know, I'll say this clearly, all women with ovarian cancer should get genetic testing. In the past, we had to choose who would get genetic testing, but even if you have 0 risk factors, you're not Ashkenazi Jewish, you don't have a family history, you're older, all women with ovarian cancer should get genetic testing, because we do find cases of BRCA mutations in those groups of patients. And now it's not only for your own personal health, but there could be familial implications, and not only for your personal risk of other cancers, but for treatment as well with the PARP inhibitors.
So there's a lot of conversation about genetics, but we have a question from a young woman who is diagnosed at age 22 with triple negative breast cancer, and at 25 with germ cell ovarian cancer. She had genetic testing done, nothing was found. She's now 26. She's had 2 surgeries and chemotherapy. She wants to know your feelings on what you would say would be another reason for ovarian cancer if nothing is found in her genetics.
Yeah, so first of all, Shanta, thank you for sharing your story. I know it's difficult, and it's difficult to open up to, you know, to a room full of 50 strangers. So based on what you're sharing, there is no relationship. There is no genetic hereditary relationship between triple negative breast cancers and germ cell tumors of the ovary. You know, they're both cancers. Obviously, they're both devastating diagnosis. diagnoses. The good news about the germ cell tumor is there's a very, very, very high treatment rate. So unlike the typical ovarian cancers, high-grade serous, BRCA-associated, occur later in life, patients with germ cell tumors have a much higher chance of doing very, very, very well. So I hope that you're in that group. You know, the interesting thing about genetics, we know what we know now, but we're still going to learn more. You know, science is progressing. It used to, you know, now we can get a full genome sequencing back in a short period of time, and it's not prohibitively expensive. You know, 10 years ago, we weren't even considering that. So, but that being said, there are still some genes and some hereditary syndromes that we haven't identified yet. And as we continue to do genetic testing, we may. But in your particular case, and if you're BRCA negative, I would say, and patients don't like this sometimes, or they do, your reason for getting cancer may be more bad luck than anything else. It doesn't mean we shouldn't continue to investigate.
Okay, and that kind of helps us with our answer to one question of how hereditary is ovarian cancer if everyone's BRCA negative. So I know that at Sharsheret, we have many families where breast cancer and ovarian cancer is on many of the female members, but there's still no known gene. So it goes back to what you said, that maybe there's still much more to discover, but does that help answer the question, how hereditary is ovarian cancer if everyone is BRCA negative?
Yeah, no, I think one of the big risk factors, as you know, as we're saying, one of the big risk factors for ovarian cancer is hereditary factors. There are other genes that are sort of homologous repair deficiency genes that are not BRCA1 and BRCA2. There's RAD50. There's really a CHEK2. There's a whole list that can be associated with ovarian cancers. HNPCC, or hereditary non-polyposis colorectal cancer syndrome, can actually cause ovarian cancer as well. So hereditary ovarian cancers don't have to be limited to BRCA, but hereditary cancers really still only make up 15 to 20% of the cancers. Again, and you know, the scientific word is sporadic. I like to say bad luck. There's still, most of the cancers are not hereditary in nature, unfortunately.
Okay. We have a very specific question, so if it's not something that you can answer on this call, let us know. But someone is asking a question about doing surgery for a third recurrence. She has a 2-centimeter tumor in her abdomen, and her oncologist says that if they do surgery, it'll just grow back since it's after the first recurrence. Now, I know we don't make any diagnoses on these calls or anything. This is supposed to be general information. Is there a general way you can answer this question?
Yeah, I would say that, and that's a great question, and I appreciate the sensitivity, you know, to personal issues. I would say, you know, the more recently studies have shown that we don't reoperate for recurrent disease. There was a study done by my friend Rob Coleman out of MD Anderson, who showed that giving chemotherapy is just as good as surgery and chemotherapy. And recently there was a European study which said patients had to be very, very highly selective. You know, that being said, I recommend that you see a seasoned gynecologic oncologic surgeon who, you know, it's not their first or second year in practice. They see a lot of cases, and everyone should be treated as an individual. So have I operated on patients for a third or fourth recurrence? Of course I have. Even with the studies there, but everyone should be treated differently, and you deserve an opinion from an expert in the field who can, you know, give you your best chance of living, to be honest.
Okay. There's a question, is it easier to have access to PARP now? There was thought that it was not freely prescribed to anyone. How does that change recurrence rates?
Yeah, so real quickly, the answer is yes. For patients with high-grade serous ovarian cancer in the maintenance setting, the FDA recently approved a drug, niraparib, which is made by GSK, that's Julia, for first-line maintenance in all patients with ovarian cancer. If that means if they respond to first-line therapy, they can get a PARP inhibitor. There's another FDA approval recently based on something called the Paola study of a drug called olaparib with bevacizumab. So it's a combination in first-line maintenance. That's for patients who have this HRD marker. And in the second line, there's a PAN approval for all ovarian cancer patients. So ultimately, it's what doctors practice based on FDA approvals, and with these FDA approvals, insurance companies are more readily willing to pay. I will say, and you know, as I mentioned earlier, I do work for all of the PARP companies. They all have patient access programs, which are pretty reasonable. And again, it's not up to me to say what's reasonable or not for someone else's finances, but they are pretty reasonable. I know a lot of patients who are originally given the no from the insurance company get it at pretty reasonable cost.
Okay, so we've talked a lot about diagnosing and diagnosis of ovarian cancer, but the question is coming in: what is happening in developing a diagnostic? You know, I know at tertiary, everyone always says, "Oh, there is no mammogram for ovarian cancer." What's the developments in that area?
So one of the areas that we're looking at, and it's interesting, and I've been doing some research with Bob Best and Robert Knapp, and those, if you don't know those two, those are the two that invented the CA-125 test. Bob Best is still at MD Anderson, and Robert Knapp is retired down here in Florida. They're looking at CA-125 a different way, not just to say is it normal or abnormal, but they're looking at it to see, compared to one's own baseline, to see its rate of increase. So they're seeing that if the CA-125 value goes up, even if it stays below that 30 or 35 level, but if it goes up compared to the baseline, in some of those patients, they should be sent to a gynecologic oncologist or at least have an ultrasound. So some of that preliminary work is being done. It's actually published from the MD Anderson group with Karen Liu that I've worked with them on. But, you know, it's not really ready for non-investigational yet, but I think it may be sometime in the future. Right now, I would not recommend that you go to your doctor and say, draw a CA-125, because what that does, if it's not being looked at in a special way, it leads to too many unnecessary surgeries, and unnecessary surgery can have its own morbidity and mortality. So I'd be very careful about that. But yeah, I mean, but yes, in summary, we need to do better at early identifying ovarian cancer.
And when you talk about the CA-125, they want to know if you say to go for a scan and see what's going on if it goes up, but what else could cause it to go up if there's nothing suspicious found on a PET or a CT scan?
COVID, and really anything, and I'm saying it half jokingly, anything could cause the CA-125 to go up. Gastroenteritis, a bad cold, you know, you're stressed out a little bit, a urinary tract infection. So what I tell patients all the time, it's if a CA-125 goes up, the only thing that tells us to do is to get a CAT scan. Or a PET scan, some sort of imaging. An elevated CA-125 by itself is not recurrent disease. It raises red flags, and it's something that we need to look for, but it's not recurrent disease. But that being said, in all seriousness, it is a good marker. So when it does go up, we take it seriously, and we look to make sure there's no cancer anywhere. Okay,
we have a question that came in. This woman said she was told that after treatment, it's common for doctors to continue monitoring ovarian cancer survivors through blood work, CA-125, and CT scans beginning every 3 to 6 months and then every year. Her question is, with the recurrence rate so high, and she's heard as high as 85%, why do they continue monitoring with more time in between scans? Wouldn't it make more sense to test and scan more often as we get further away from treatment rather than testing less often?
Yeah, no, that's a great question, and that's a question that we consider all the time. The reality, if we had a great treatment that works as soon as we diagnose the recurrence, then we would do that, right? Because we want to diagnose the recurrence as soon as possible and give that great treatment and prevent the cancer from growing anymore. Unfortunately, we have good treatments for recurrence, but they're not great. So if a patient's asymptomatic, they're doing well, there's maybe a little bit of disease going on. I'm not saying it's not something we shouldn't take seriously, but allowing them to live their life and waiting for another scan in 3 months isn't causing them to live or isn't decreasing their survival at all. If anything, it's giving them 3 months of a high quality of life without a cytotoxic therapy that can cause some side effects. So identifying it earlier makes sense only if we could actually do something that's highly effective. While our treatment for recurrences are good, we're not really missing out if we waited 3 months. If anything, we're giving patients more time that's symptom-free without therapy.
Thank you. If the cancer is in the peritoneal lining, is that different than ovarian cancer or no?
Yeah, that's a great question. So there is a subtype of ovarian cancer called primary peritoneal cancer. And we know it looks like, it acts like, and it plays out like ovarian cancer. Under a microscope, it looks the same. Oftentimes, even if it doesn't originate from the ovaries, it affects the ovaries. And we know it's ovarian cancer because men don't get it. It's only found in females. Those primary peritoneal cancers, actually, we treat just like ovarian cancers. We give them the same therapies. We put them on the same clinical trials and things like that. And the prognosis and treatment is about the same. So yes.
Okay, and then there's just a question about fertility and ovarian cancer. There was discussion about just removing fallopian tubes, leaving ovaries, mostly for prophylactic purposes for those who have BRCA mutations. Is there new information about what should be removed? Is there a risk by leaving in your ovaries? What are your thoughts on that?
Yeah. No, that's a great point. And more recently, we're learning that the fallopian tube may be the site of origin for ovarian cancers. So particularly in our younger patients who are BRCA positive, there's some who speculate by just removing the tubes, leaving the ovaries in, that could decrease the risk of cancer and help maintain premenopausal state. And if patients want to do IVF or become pregnant, they could still do that. I still think that's experimental. In general, the recommendation for patients with BRCA is to do an oophorectomy and removal of tubes at the age of 35 or when childbearing is complete. But there's always exceptions, and I do think that there are some cases that we can maintain fertility a little bit longer. But in those patients, I would do more active surveillance with CA-125s and ultrasounds to make sure that we're not missing something that we could catch pretty early. The problem is, and in summary, what I'm saying is early stage ovarian cancer has a 95% survival. It's when it becomes late stage that's more deadly. So we really don't want it. If possible, we want to remove the ovaries before it becomes advanced stage disease.
Okay, and then there's a question about, they just want a clarification for something you said earlier regarding monitoring. Do you mean it does not change morbidity rate if it's caught at 3 months versus 6 months versus a year?
Yeah, so it doesn't. So basically, when you catch the recurrence, so I'll give you an example. In the United States, we use CA-125 as a marker to see when it recurs. If the CA-125 goes up, we go out, we get a CAT scan, we diagnose if there's recurrence or not. There was a study done and comparing what we do here to the United Kingdom. In England, they don't do that. They only treat recurrences based on symptoms. What they found was the survival in both groups were exactly the same. So even though we caught recurrences early, the overall outcome, if given the best therapies, are about the same. So I do, in my practice, year 1 every 3 months, year 2 every 4 months, years 3 to 5 every 6 months, and then yearly thereafter. But which I think is a reasonable approach. I wouldn't do it any sooner. But no, if you miss a recurrence at 3 months and you get it at 6 months, for the most part, the outcomes will be about the same.
Okay, I think we're good. I think you answered a lot of questions in a short amount of time. I'm really glad that this is going to be taped and people are accessing Sharsheret website, where we have a whole suite of virtual programs and services to help women at all stages of cancer, before, during, and after diagnosis, even into survivorship. And I think the information that you're sharing, ovarian cancer, is critical. So thank you for your time and your expertise. Thank you, Kim, for sharing. We do have a peer support network with thousands of women, and we can match women one-on-one based on their diagnoses, based on their issues and concerns. So if this is something that you want to benefit from, everything is confidential, everything is private, everything is made to be convenient for you. We know you are busy, we know you have a lot going on, and you don't have a lot of time for this, so let us take care of that for you. I just wanted to let you know that if you or anyone you know is going through something and they want to reach Sharsheret, we are here, open all the time, www.sharsheret.org, 866-474-2774. You can find us on Facebook, you can find us Instagram, LinkedIn, wherever you are, we are. We can speak with you, we can help you, we are there for you. So feel free to refer friends, family, or even yourself. Everything is free. We have upcoming webinars. We have a really exciting Paint With Me night, an opportunity for cancer survivors, no matter what stage you are, to join us for an evening with a feel-good night, paint night, together with a a wonderful leader who can help us all paint the same painting at the same time. And it's really a fun, feel-good evening that's happening on July 8th. And we have updates with the latest cancer information from ASCO on Thursday, July 16th. So I hope you'll all join us. And thank you, Dr. Slomovitz, and thank you, Kim, for your time. And thank you all for sharing your questions. Everything that happens stays here, and we're a happy group to stay together and share experiences. And we wish everyone continued good health through this pandemic into a brighter future where we can all be together in person. Thank you.
Great. Thanks, everyone.